Greetings to all of you who've joined us today. We have more than 1,000 dedicated colleagues and champions who've registered for our conversation, and it truly is my honor to steward our discussion as we reflect and recommit to a shared vision to accelerate access to family planning as core to sexual and reproductive health and rights. And of course, our shared ambitions for gender equality, health equity, and economic achievement for all people. My name is Nabeeha Kazi Hutchins, and I serve as President and CEO of PAI. We are a 59-year-old civil society organization that has been steadfast in advocating for global sexual and reproductive health and rights as fundamental to gender equality, health equity, and the resilience and prosperity of all people. We do this through our ongoing advocacy to the U.S. government, which is the leading funder of family planning and reproductive health programs globally, and our vibrant partnerships with multilateral institutions like UNFPA and with our extended ecosystem of 1,800 local, independent, grassroots civil society organizations in over 60 countries. And together, we advance the promises that we have collectively made in the ICPD program of action. We mark the 30th anniversary of ICPD, and I can see no better time than now to reflect on the progress that we've achieved, acknowledge the unfinished agenda, and chart a bold path forward. And to kick us off today, it is my great pleasure to introduce leaders of our movement whose institutions are at the forefront of enabling our ambitions for family planning and sexual and reproductive health and rights. And they are Shyami de Silva, who is the director of the USAID Office of Population and Reproductive Health, and Ayman Abdelmohsen, UNFPA's Chief of the Sexual and Reproductive Health Branch. Thank you, Shyami, and thank you, Ayman, for joining us. Welcome, and the virtual floor is yours.
Thank you, Nabeeha, for that introduction, and welcome to our online audience and esteemed panel. I want to also thank Ayman and UNFPA for the opportunity to have this conversation and to further strengthen the partnership between our two organizations as we focus on promoting reproductive health and access to family planning for millions of women and girls across the world. As the leading bilateral and multilateral providers, respectively, of international family planning and reproductive health assistance, USAID and UNFPA stand together as global leaders and long-standing partners with a shared commitment to advancing sexual and reproductive health and rights and upholding the ICPD agenda. 30 years ago, in 1994, the US government was one of the formative champions of the ICPD program of action. The Cairo Consensus, as we know, represented a sea change, with 179 countries agreeing that sexual and reproductive health and rights needed to be centered not on population control, but instead on autonomy over one's own life and body, including the decision about whether and when to have children. Today, we remain committed to that mission. At USAID, our SRHR efforts include providing voluntary family planning and reproductive health programming and technical assistance in more than 40 countries around the world. Foundational to our efforts is a commitment to helping realize a world where ongoing improvements to sexual and reproductive health contribute to longer, healthier, and more prosperous lives for all. USAID works in partnership to expand access to high-quality health services, promote healthy behaviors, broaden the availability of contraceptives, and strengthen policies and systems to address a range of family planning and reproductive health needs. Through those and other efforts, we reach over 24 million women and couples around the world each year with the family planning and reproductive health products and services they need to plan healthy families and build brighter futures for themselves and their children. While our collective efforts of the past 30 years have helped to improve reproductive health outcomes globally, including improvements in satisfying demand for family planning and reducing preventable maternal deaths, there is still much to do to achieve the goals of sustainable development and deliver on the promise of ICPD. And I want to mention just a few of those, the most critical challenges that remain. Still, 44% of women in union lack autonomy over their health, contraception, and sexual decisions. Globally, 257 million women and girls have an unmet need for family planning, and this number is expected to rise to 271 million by 2030. Each year, 500,000 births occur among girls aged 10 to 14, and about 800 women die in childbirth every day, with most of these deaths occurring in low and middle income countries. Compounding these challenges is what's essentially static donor funding for family planning and reproductive health globally. And while inflation continues to rise and the number of women in need of SRH information and services continues to grow, that actually translates to decreasing donor resources. It's clear that in the face of these persistent challenges, we will need to use our resources strategically, making it even more critical to have access to high quality demographic and health data that help us to identify and reach the most vulnerable and marginalized communities. To meet the challenge of fully realizing the ICPD vision, we will need to continue to mobilize resources from across a broad range of partners, including governments, donors, international financial institutions, to close the financing gaps for SRH and accelerate the transition to more sustainable financing. At USAID, we remain committed to ICPD and to working collaboratively with our partners to prioritize country leadership and sustainable financing to deliver on the vision of the program of action. We have recently launched a new programmatic guidance document for family planning and reproductive health entitled Pathways to Progress for Sexual and Reproductive Health that provides really a comprehensive technical framework for USAID programs to accelerate progress towards global SRH goals. And we also note that there's considerable strategic alignment between this document and UNFPA's 2030 family planning strategy to end unmet need that you'll hear about in a moment. We are pursuing new approaches to SRH financing that support governments to gradually increase domestic expenditure on SRH and maternal health commodities over time. And this shift from funding to sustainable financing has already resulted in increased government commitments to domestic resource allocations for family planning. USAID is also supporting family planning progress in 9 Francophone West African countries through an expected $86.5 million in family planning and reproductive health funding over the next year. And these countries of the Ouagadougou Partnership report some of the lowest contraceptive prevalence rates and highest maternal mortality ratios in the world, yet have historically received less donor investment than other regions. We are strengthening supply chains in low middle income countries in partnership with governments to ensure contraceptives reach those who need them by enhancing data, communication, and visibility of supply chains through the Global Family Planning Visibility Analytic Network. And we're working to strengthen family planning service delivery as part of primary health care and supporting the prioritization of both funding for SRH in national budgets and laws and policies that facilitate access for underserved and underrepresented populations. Many of these efforts and gains would not have been possible without our close technical collaboration with UNFPA. I hope that today's discussions will present an opportunity to strategically build off of that partnership, further strengthen our connections, and shape a shared vision of SRH for all, including universal access to family planning. So many thanks to all of you for your participation today. And with that, I'll turn it over to you, Ayman.
Thank you very much, Shyami, and good morning, good afternoon, good evening to all. And thank you to USAID and the global community for being here with us today. I would also like to give a warm welcome to the countries that are represented with us today from Kenya, Sierra Leone, and Nigeria. And of course, to the civil society partners like EngenderHealth from Tanzania, Samasha from Uganda, and of course, Nabeeha and our long-standing advocacy partner from PAI. Today, I'm honored to join you to reaffirm our collective commitment to the ICPD Plan of Action. And before I start speaking about what the collaboration we are, I would just like to inform you that I participated in ICPD 1994 in Cairo. It's my home country. Gives you an idea about how old I'm getting. But honestly, it was a real change in my heart and mind. I attended it as a gynecologist, an obstetrician gynecologist who always looked at the issues of women's health from the curative point of view. And I really learned from that day that it is a human right. It's a personal human right. It's a fundamental human right for each and every woman and couple and family to be able to make informed decisions about their families, their size, when to get pregnant, how many children, and so forth. So it was really a turning point. And to my mind, and I'm sure to many others, it's been a beacon of hope for millions of women and girls around the world. So 30 years ahead, we have achieved so much, but we still are to achieve more. We've heard from Shyami about some of the incredible strides we've made forward, and I'm sure you'd agree with me that there is so much more work to be done. We continue to face unprecedented challenges that threaten to reverse the progress we've made over the past 30 years. The world is changing faster, much faster than ever before, and our strategies must change to face these challenges. Business as usual will never be able to make us serve the women, the 257 million women that Shyami referred to. The shifts in the structure of population is evolving. There is a critical juncture between sexual and reproductive health and rights and the whole issue of population dynamics that we need to face. 30 years later, the promise we made in Cairo is more important and fundamental now than ever. And as long as we allow the current inequalities to persist and grow, as long as half of our population is being left behind and underserved, we cannot move forward. So that's why we need to change and we need to adopt new approaches. We cannot rely on these old strategies that we've used in the past. We need to forge a new path forward, one that centers on country leadership. That is very important and empowers government to prioritize and invest in sexual reproductive health and rights. This means transitioning from reliance on external aid and donors to sustainable country-owned system. And this is where UNFPA and USAID have joined forces over the past few years, recognizing the strong coordination is a key to success. And we started working together on developing a joint work plan on domestic financing to align our effort at both global and country levels. Through joint initiatives like practice groups, training resources, advocacy, we are building the capacity, working very closely with our country governments, empowering countries to take ownership of the future of their sexual and reproductive health and rights. The good news is that this transition is already underway. Governments are already stepping up to make bold multi-year commitments, building reproductive health, including family planning, into their national strategies, and most importantly, into their policies and budgets. This is the type of leadership the world currently needs. To support this shift, UNFPA is committed to expanding access and strengthening health systems and empowering women and girls through our family planning strategy that we developed for the years 2022 to 2030. Through initiatives like the UNFPA Supplies Partnerships, we provide technical assistance, we leverage innovative financing mechanisms, and we work hand in hand with governments to strengthen health systems and ensure uninterrupted access to essential health services. We have shifted our focus, especially towards sustainable financing, particularly domestic financing, and integrating family planning within the overall universal health coverage. Significant strides have been made in this direction. In 2023, for example, we've been able to successfully establish 44 compact agreements with our governments, where each and every government committed to leading and increasing domestic financing for reproductive health commodities in 2023. Moreover, through another incentive mechanism that we've established, the UNFPA Supplies Match Fund, it is an innovative mechanism that supports government to gradually increase their domestic resources for quality-assured reproductive health commodities. Through this mechanism alone, which has been awarded to 21 countries, we've been able to mobilize an additional $15.9 million in domestic resources since the launch of this mechanism. So we have so many interesting examples to face these challenges, but we feel that the global community need to work together on these domestic investments. Domestic expenditures among partners countries amounted last year to almost $44 million for contraceptives. That's a significant increase from $10.4 million in 2020. So I don't want to belabor my opening remarks. We need to recognize that this change will not happen overnight. It cannot. And it cannot, and for it to change, it needs to be a long-lasting and sustainable change. Therefore, we the donors and partners must continue to support countries as they work to realize this transition. It is clear that we will all need to work together to advocate and mobilize resources from the full range of partners, including governments, donors, international financial institutions, the civil society, and the private sector, if we are to close this financing gap. All of you, our partners, are crucial players in this work, and we must remain steadfast in our support of countries as they make this necessary shift, while working together to strengthen health systems, to be resilient and adaptable so that people do not lose access to contraceptives and life-saving maternal health medicines. I would like to close by thanking again the huge partnership of USAID, the leadership of my friend and colleague Shyami, and to all our government and civil society partners that we've been working together to face this interesting challenge. I will give the floor back to you, Nabeeha, and thank you for opening the remarks.
Thank you so much, Shyami and Ayman. We know that our movement is fueled not only through your institutional commitments, but also thanks to your steadfast individual commitments and your powerful and courageous voice. And all of this continues to elevate priorities, progress, and impact. I'm now thrilled to move into a conversation with those who are making family planning aspirations and ambitions a reality. They're shaping and stewarding family planning and sexual and reproductive health policies, advocating for domestic resources, building community awareness and rights literacy, and ensuring that what gets promised gets delivered. With us, we have 4 distinguished panelists. I'm going to introduce each one of them, and then we'll go into the Q&A portion of our discussion today. So the first is my pleasure to introduce Dr. Bashir Issak, and he serves as the Director of Family Health, Family Planning and Family Health at the Ministry of Health in Kenya. Dr. Bashir is currently entrusted with the expansive role of overseeing the Directorate of Family Health, managing a range of vital divisions that are encompassing maternal and reproductive health, child health, community health services, mental health, and tobacco control. We also have Dr. Tom Sese, who is the Director of RHC at the Ministry of Health of Sierra Leone. He's an experienced medical officer and public health specialist who has over 20 years of experience in health services in Sierra Leone, with many years working on maternal and child health services. Next, we have Cornelia Asiimwe, who serves as Executive Director of Samasha. Samasha is a civil society organization that is based in Uganda and provides technical assistance to improve family planning and sexual and reproductive health through their advocacy and accountability work, as well as health system strengthening and health innovations and technologies. And last but not least, we have Dr. Anna Temba, who's the Technical Director and Deputy Country Representative for EngenderHealth in Tanzania. And EngenderHealth is a leading global health organization that's committed to advancing sexual and reproductive health and rights and gender equality. Dr. Anna is a medical doctor and public health specialist and brings over a decade of clinical program and technical experience. panelists, my most heartfelt welcome to you. By the way, as a reminder to the audience, our Q&A function is open, so please post your questions and my colleagues will be sharing those with me for the audience Q&A portion of today. So let's get started, and we'll go in the order of my introductions. So my first question is that each of the countries that are represented here signed onto the ICPD program of action. And this program of action made family planning a central human right. 30 years later, what are the most pressing barriers that you see to ensuring universal access to quality family planning services? And how can we overcome them to fulfill the promise of ICPD? So again, we'll start with you, Dr. Bashir, and go on to Dr. Sase, from there, Cornelia, and Dr. Anna.
Thank you very much, Nabeeha, the panelists. I think we've covered a lot of grounds since ICPD 1994, but we still have some barriers. There are some which are very deep-rooted, barriers like the myths and misconceptions that are around the perceived side effects on the same, the preference of some religious groups becoming a barrier is still a reality. But the main ones that we are facing right now is inadequate the regional disparities. In Kenya, we have countries that have a CPR of 75–80%, and some which have the huge disparities. This is quite a challenge for us. The industrial actions that we've been experiencing since devolution in Kenya is something very critical that affects. Of course, we have to mention COVID, the loss of gains that we have done during COVID, and also social and behavioral change demand creation activities, particularly in areas with a low uptake. So in terms of the strategies to overcome, I believe we need really to revamp. There's a change of government, for example, in Kenya, and this current government doesn't look at family planning as a priority area of investment. And there are a lot of other social issues. I'm sure you've seen it in the social media that there's a lot of upheaval of the young generation in Kenya. And therefore, family planning becomes the culprit and the sacrificial lamb in terms of budget cuts. We've been allocating a lot of money, and we have commitments with our partners, UNFPA, Bill and Melinda Gates, FCDO, that come 2026-27, the government should be able to fund its family planning commodities at least. But we have regressed quite a lot in the last 2 years with this new government, including even vaccines and HIV/AIDS commodities. So family planning does not come on top of their top priorities, and usually leadership is in the hands of politicians, and politicians don't look at family planning as an important aspect of national development. We took time to educate the previous regime, and family planning was really protected. But right now we have lost those gains, and the financing, lack of financing from the government's own pocket is becoming something that is much more difficult than before. Of course, therefore, we need national advocacy for commodity security and family planning services at national treasury and also at the leadership, including the presidency. Enlisting family planning champions within the religious groups who are few and who have seen the light is something important. And improve availability of family planning services, especially to the women that deserve and those who are left behind. 2% of a population in a few counties, and 80%. This disparity has to be dealt with. This inequity has to be dealt with. And over to you. Hope I have taken my time and I have not overspent my time. Thank you.
Thank you so much, Dr. Bashir. We'll go with Dr. Sase. Dr. Sese, can you hear us? Okay, we will come back to you then. Perhaps Cornelia, you could provide your reflections on this first question.
Thank you. Good morning, good afternoon, good evening. Once again, I want to take a moment to thank USAID and UNFPA for this great webinar. And for me, one of our submissions, I think, is that we have done a lot towards ensuring that we move and achieve our ICPD goals, but we continue to have challenges at the community level. The demand generation continues to persist. Our recent Uganda Demographic Health Survey showed us that our demand for family planning currently stands at 66%. That in itself shows that there is still much more that needs to be done. We do not have strong follow-up systems that we need to be able to put in place to be able to deal with the myths, the misconceptions, to deal with the uncertainties around the side effects. But then we also need to be able to have accountability structures where the communities themselves are able to acknowledge and know that they have a role to play in holding the duty bearers accountable, that they too have to be able to ask the right questions on how do we be able, what are our rights, what do we need to do, how do we engage with the health facilities. We also know that even when we are having the outreaches being done, they do not happen in all the facilities. They do not reach the last mile, and we're seeing that we're having missed opportunities here, and it is important for us to see how we can be able to strengthen that. And that comes by empowering these communities to be able to demand more, to ask for more. But we also want to take a moment to appreciate and say that even with the funding or with the investments that the different partners have been able to do, how can we be able to hold them, have this transparent, so that beyond just having the commodities and that we are having and said we have procured them, but can we actually be able to sit and see that these commodities are actually being used, that we are having them delivered to the facilities that need them? And how can we also be able to strengthen some of the integration models, learning from the peer-to-peer, learning how we can sit and leverage the youth platforms, the adolescent and youth platforms, to be able to increase access for those special groups and also be able to improve equity. And we also see that it is important for us to deal with the stockouts. In as much as we try to be able to want to provide more, we still have challenges around the method mix, and it is important for us to be able to see that we can still be able to provide a variety of the different options, whether it is short-term, long-term, or even the permanent methods. Thank you, and over.
Thank you so much, Cornelia. You've raised such a great perspective on what the community needs. I'd like to move on to Dr. Temba, and then hopefully we'll have Dr. Mohammed, who may be, sorry, Dr. Sese to potentially join us as well. So Dr. Temba, over to you.
Thank you, Nabeeha, and thank you for having us. So I would also just like to appreciate, organizing this webinar, but also appreciate all the gains that have been achieved so far. But I would just like also to highlight a few barriers that are still persisting. So one is ensuring quality and inclusive services for everyone, including young people and people with disability. For example, in Tanzania, with the current TDHS, even the regions with the highest CPR still face the highest teenage pregnancies. And again, even for people with disability, it's even hard to track how many of this population have been able to access family planning services. For example, EngenderHealth, in collaboration with various partners, including Disability Umbrella Organization, has been doing various activities and interventions to increase access for people with disability, such as training, advocacy, but also quality assurance and tracking method mix and compliance to ensure non-coercion and informed choice. But we still see quite a few challenges, such as tracking and monitoring PWD access to services, capacity of healthcare providers, but also the infrastructure barriers. So this is, again, one of the areas, if we really want to have universal access and leaving no one behind, that needs to be addressed. Secondly, there are still persisting harmful social and gender norms that impede women access to full range of contraceptives, and specifically a method of their choice. And therefore, efforts to increase availability of services need to go hand in hand with actually empowering women to make decisions regarding their method of choice, to make joint decision with their partner, but also to negotiate their contraceptive use. We need to invest on capacity strengthening on the gender competences for healthcare providers. We need to engage men on board. We need to bring them on board as supporters, users, but also as agents of change. They are men who are positive. They provide a positive picture as users of FP, but also as supporters. So we also need to bring them on board. But we also need to implement FP programs that are also coupled with gender transformative initiatives. And empowerment comes in a big picture, and there are quite a few opportunities that we can link our clients with various opportunities that exist within their communities to empower them either with education or economic empowerment. Lastly, I would also like to highlight the barrier when it comes to human resource for health. In Tanzania, for example, we have less than 50% of the required human resource for health. And this affects service provision. For example, family planning counseling, family planning service provision, or even removal. So you can imagine for a healthcare provider who is overburdened, and they have to choose which method they're talking and providing to a client, they'll most likely provide a method that is fast, probably a short-acting method, even if a client wants a long-acting method like an IUD. And if then the counseling is not adequate, we know this affects also the client satisfaction, as well as how they manage and perceive the side effects. So we also need to invest on the human resource for health. We need to explore ways that we can improve task shifting and task sharing, but also explore other opportunities such as self-care, but as well as service integration. Thank you.
Thank you, Dr. Anna. All such important points, and I think also underscoring the critical nature of client satisfaction and the human resource piece, as well as the human element of what is it that communities want and will find acceptable. I'm going to go back to Dr. Sese and see if you are able to hop off mic and answer that first question for us.
Yeah.
Dr. Sese, we're unable to...
coming on and off, so I don't know if you can help me with remind me in Ethiopia, and I think the network is a bit bad guy. I'm not sure.
Dr. Sese, we're unable to hear you, so perhaps we can move to the second question, and you may be able to join us after that, after we go through a first round. We're just having some difficulty hearing you. So Dr. Bashir, back to you, and this question as well to all of our panelists. We know that there are clear shifts that are underway in the funding landscape. I know this is top of mind to so many of you on this panel and those of us who are attending. This transition away from donor funding to sustainable financing is also underway. It's a very important topic, especially through the allocation of domestic resources at the country level. Would love to hear your perspectives on what you see as the greatest opportunities and the greatest challenges in your own country's ability to fully realize this transition to where the domestic resource component to support family planning and sustain sexual and reproductive health services and support can be realized. So Dr. Bashir, over to you.
As alluded to earlier, we were doing very well. Few years ago, and sometimes we were almost covering 60–70% of our commodity security in terms of family planning. I'm concentrating on the commodity security because that's the first thing. If the information awareness of family planning is well taken in the community, and even they are against family planning, but the population is using, and our is 64%. So in the last decade, we have covered quite a lot, and that was because of commodity security. So our plan and our focus right now is to ensure commitments with our partners, is to ensure that we avail the products to the clients where they want. And therefore, main challenges right now is the change of government has really brought huge challenges in family planning.
Seems we may have lost Dr. Bashir. Dr. Bashir, we can't hear you.
I think stable. Yes, so let me just, can you hear me now?
Yes, we can. Thank you.
Can you hear me?
Yes, we can hear you, Dr. Bashir.
Okay, let me put off my camera. Maybe I'll save some data bundles. So
Unfortunately, we've lost you again, Dr. Bashir. So perhaps we can go to Cornelia, if you could provide.
budget for family planning. If I could provide.
Oh, Dr. Bashir, you had cut out, but please continue. Hopefully, we'll be able to hear you now.
Yeah, funding gaps and budget cuts have been a reality, and we seem to be hitting a wall in terms of convincing the National Treasury to really allocate resources. Before, the National Treasury team that was there was really trained. We have invested a lot of time in them, and it was a no-touch area for budget cuts. This year and last year, we got huge budget cuts, and with the house in the country now, because of a lot of repression and a lot of discontent in the community, the finance bill has been rejected by the population, and therefore family planning doesn't really appear anywhere. And we need to invest in that area to bring the National Treasury team on board that family planning is a development agenda and it's not just a health agenda. Procurement and distribution delays. When we procure, it takes about 9 to 12 months for the commodities to be delivered, and this needs to be really fast-tracked. The data accuracy and monitoring, we have integrated LMIS systems in place, but I think this is not everywhere. The issue of digitizing of health systems will really come in very handy. And then there's resistance to change. The politicians and even the market. The issue of the total market approach, where as it is right now, family planning commodity is free for both private and public facilities. A total market approach where they should be able to have their own commodity supply chain, and we don't have that at the moment. So the kind of opportunities that we have is for us to really hammer very well the message that family planning is a development agenda. We have an agency in the government called National Population and Development Agency, which main role is to really foster and educate the leadership in terms of family planning as a service delivery arm, but a development agenda. Enabling policy and legislation environment, this we've really done. We are also working on a family planning policy to ensure that the resources allocated to family planning in the government is ring-fenced. And our commitment with our partners, the MOU we signed with our donors, Bill and Melinda Gates Foundation, USAID, and FCDO in 2021 stands, but I must report here that we were not able to meet our commitment on the side of the government because of these externalities in terms of the change of government, a lot of other national needs. Agreement with UNFPA, and Kenya has paid its component of the reimbursement of 172,600, albeit with a lot of difficulties and push. And therefore, we hope to sustain this and put it in the budget to eternity. And then the county level, we have a devolved system of government where the health service is devolved. We have had that all the counties to develop their costed implementation plan for family planning. program, and they fund at their own level, as the national level is also looking for resources to really buy the products. So there is hope, but there are a lot of challenges that you don't anticipate. We thought we were out of that, but we were back to the whole of challenges of really defending family planning at the National Treasury for resource allocation. Over to you. Thank you.
Thank you, Dr. Bashir. Clearly, the work is not done, or is it over? And we always have to be watchful, but it's so exciting and very important to hear the fact that there is a dedicated agency within the government, but also looking at this from a national perspective as well as from a county and subnational perspective for financing. So it is very encouraging and excited to hear more about this as we continue the conversation. Cornelia, over to you, and then perhaps Dr. Anna, you can also weigh in on this question.
Okay, thank you once again. One of the challenges that we have had is that right from the ICPD commitments that we made, these have not been domesticated or translated at country level. And you see that it is important for us to be able to go back and understand what it is that we wanted to do. How can we be able to build the capacities or strengthen the capacities of the CSOs or the partners that are actually going to help us to support the government and the partners to achieve these commitments. We know that we have our costed implementation plans. We have the RMNCH investment cases where family planning has been prioritized, and we see that a lot of commitment has been geared there. But we have seen that the implementation of these is still weak. And when it goes down to subnational level, it gets weaker. And it is important, we think that it is very important for us to be able to go back and domesticate and bring this. How can we translate some of these policies, some of these strategic plans, and take them down to the communities, take them down to the districts that are able to do that? And the other thing we have also seen is that the power of the involvement of the subnational partners themselves, the subnational local governments. In Uganda, we have seen that from our experience with the domesticating the costed implementation plans, we have seen some districts, about 36 of them, allocating some of their domestic revenue towards investing in family planning, including activities focused on adolescent and responsive young health. And these are spaces that we think we can be able to leverage and be able to take forward going also. But you also see that it is important, just as Dr. Bashir mentioned earlier, how can we be able to address the pipeline gaps? Because once the supply is delayed, it affects the demand, and which is, they do not tally. And it is important for us to see that we try very hard to see that these commodities are actually at the facilities where they need to be accessed by the communities that actually need them. And then we also see that accountability continues to be important. And for us to be able to strengthen that, it is about empowering the communities to be able to sit and say, what are our commitments? What do we need to do? Beyond just saying we are holding government accountable and saying, oh, government, you're not doing your part, or you committed to 5 million, but you have not made that. But how do we come back and ask ourselves the same question? What do we need to do different as partners? And I'm here speaking as civil society to be able to say, what can we do? How can we be able to support the government to be able to achieve this? And we have seen from my experience in doing the budget accountability in 7 countries that the government investments are there towards family planning, but these are centered around the commodities, and the monies that are allocated will actually be spent on the procurement of these commodities. But family planning is not just the commodity, it is about the services as well. So how can we be able to support and strengthen that and so that we're actually able to get and have them moving towards those that actually need them? I will stop there for now. Thank you.
Thank you, Cornelia. Dr. Anna.
Thanks. Yes, also building on what Cornelia has just said, Tanzania also has quite a few opportunities right now, as we have just signed the Universal Health Coverage Bill this year. And the bill really prioritizes RMNCH services, including family planning. So we know there are going to be quite a few competing priorities, such as reduction of maternal mortalities, newborn mortalities. But we also think this is a great opportunity for us all, as family planning advocates, to actually position family planning at the center of this bill and actually at the center of the RMNCH access. And another opportunity that we actually see for Tanzania is that this year we've made a huge progress as well. In the Ministry of Health budget for this financial year, it has a specific line for RMNCH commodities. Yes, it's not like a specific line for family planning commodities, but it's a step ahead from having a blanket budget for health commodities. So we know it's a great opportunity, and we know later we'll again move to having a specific line for family planning commodities, but we still have an opportunity, but as well as a challenge in tracking how much of this RMNCH commodity will actually be now allocated for family planning, and will it be adequate to actually say we are now moving to sustainable financing for family planning services. Additionally, Tanzania is among the 44 countries that signed the supply chain partnership, the compact agreement with UNFPA. And last year, it was able to disburse its 1%. This year, it has signed for the 2%. And we know, from the commitment, from the discussion, from, all the push from everyone, it's going to actually deliver its promise. We are again also positioning, we were not eligible to get the matching fund last year, but we are now taking steps to make sure that really Tanzania is among the country that is going to get the matching fund from UNFPA. So again, this is a great opportunity that we are all celebrating, I think, in terms of the civil society, because we actually seeing the movement, we actually seeing the commitment, and from the government to actually deliver on its promise is a huge step ahead, and we know we are going to advance ahead. But also building from what our colleague from Kenya just mentioned, I think we still have an opportunity when it comes to total market approach. As Tanzania is now moving to a middle income country, with more people being able to pay. And I think that's another opportunity to complement funding and to complement the family planning service provision. Thanks. Back to you, Nabeeha.
Thank you, Dr. Anna. I'm going to turn it over to Dr. Sese one more time and see if perhaps he can join us. Okay, it seems we're still having some technical issues, so let us carry on, but very encouraging to hear the progress, both from you, Dr. Anna, as well as Cornelia. Looks like we have Dr. Sese.
Yes, I'm back on. But problem is it keeps coming on and off, so I don't know whether you can hear me.
Dr. Sese, unfortunately, we're not able to hear you. So we'll continue on to the third question for the group, but certainly Cornelia and actually all of our panelists, Dr. Bashir, Cornelia, and Dr. Anna, you've lifted up both progress and some of the very significant commitments that have been made at the domestic level, at national and subnational, as well as some of the efforts underway to ensure that those gains are expanded and sustained. And so my last question before we open it up to those who are attending the conversation today has to do with the unexpected and how to mitigate some of what is unexpected. And so we are well aware, and we've all experienced and seeing that there are ongoing humanitarian, climate, and public health crises. There's a demographic reality with the largest youth population in history. And we're seeing and know that there are more elections around the world with more people going to the polls than ever before in history. There are also very well orchestrated and well-funded efforts to derail family planning and sexual and reproductive health and rights programs. And these efforts and all of these dynamics are very complex and complicated. It is a complicated backdrop. I think we can agree with that. And I'm curious, the question is, from your vantage point, what do you think is required to mitigate harm or threats to family planning and to ensure the continuity of programs, as well as the preservation, if not the expansion, of our progress today? And Dr. Bashir, we'll go with you first.
Thank you again, Nabeeha. The population, what do you call cohorts that we're dealing with at the moment in Kenya, I think 75% of our population is very young, as less than 35 years of age, and they're very educated. So the issues of awareness and the use of family planning for the population is something that is giving us hope. And the areas of focus for us to have an impact and to ensure that the gains that have been made are not lost is to have a targeted advocacy towards those who control the resources, for them to buy in and get educated that family planning is a development agenda and it's not a health agenda. Therefore, we need investments in terms of the partners. It's not time to walk away. Much as governments have committed to phasing out and increasing domestic resources, we've done that. But right now there's new team in place and governments change. So we should always have that fallback for the countries not to lose the gains. As much as we are talking about sustainability, 2026, 27 is just 2-3 years ago to come for Kenya. But we are not at the place where we were 3 years ago. We are completely back by 10 years. So the investments in advocacy and also to deal with the issues of inequity are issues that can bring us up to speed. And the discussion, the discourse at the national level, at government level, at the highest level of the presidency. Sometimes religion obscures their thinking, and some bishops come and speak something to them, like in this country, you remember there's a department called faith something, where the first lady is in charge. We cannot approach such a structure with information on family planning. So the technocrats who are the advocates and around governments and also outside government, the CSO, are having very difficult time in venturing to this. The door is completely closed. So it depends who comes to power. Just like the American bipartisan party issues, when one party comes into, the door is open. When one other party comes in, we are now realizing such a thing in Kenya, where the first lady is completely very religious, and some of the issues they don't even touch. Signing the compact agreement for me was very difficult, pushing around, just because some religious leaders have come into the space, and therefore investing in advocacy, investing in to bring out the inequities in the country, and especially commodity securities. In short, it's not time to walk away from these countries that have done quite a lot in terms of their investment, so that we don't lose. Thank you very much.
Cornelia and Dr. Anna, thank you so much, Dr. Bashir.
Thank you. And I think Dr. Bashir was in my head. For me, I also agree that it is important that we sustain what we already have. Even when we are having all these others conflicting coming up and showing us that they are more pressing, we cannot ignore the benefits that we have so far managed to have. Looking at Uganda, more than 50% of our population is youthful. Our climate prone areas are the mountainous areas. We are prone to floods. If we do not be able to sit, if we ignore them for now, even if we look at the next 10, 20 years, where are these people going? This youthful generation, where are they going? They will occupy these places. Then what happens? Our problems will just keep getting worse and worse. So we cannot ignore and say, because this is here, we ignore it. No, let's start with a very little, however little it is. Let's continue our investments and secure that we have. And then maybe a year later, once we continue to also synergize and leveraging on the power of intervention, of integration, the way we are integrating it, whether it is in maternal health, we're integrating it in HIV, integrating it in health education, in nutrition, and all the others, to be able to now sit and see, how can we be able to do more? What do we need to do different? And how can we work together? And secondly, continue the power of leveraging the people-centered advocacy. helping them to be able to ask and demand for more, because if they do not ask, they will not get. So it is important for us to also to continue to empower ourselves as the communities to be able to say, this is what we want, this is how we want it. And then our governments, supported by the partners, can help us be able to achieve those goals. Thank you, Dr. Anna.
Thanks, Cornelia. Yeah, so I think on my side as well, building on what my colleagues have said, is also we need to expand, service provision platform. For example, in Tanzania, 8 in 10 of our people get services through the public facilities. We know when it comes to crisis, that might not be the best option for continuing family planning service provision. But also, we also know from studies and evidence that that might not also be the best fit for adolescents, particularly those who have not had a child, who are actually prioritizing privacy and confidentiality, and who are probably most likely will go to a private sector for family planning services. So we need to expand and diversify where we are providing services. Yes, family planning routine services are high impact practices, outreach are high impact practice, and we appreciate. But we also need to think of other ways and other platforms. What about the pharmacies? What about the adults? For Tanzania, we have like these small drug shops, which are available and open within the communities. So what are we doing with this other service provision site to make sure that we support them to provide at least a wider range, if not a full range of contraception? But also, we also need to think around family planning service integration. We know service integration works. We have the evidence for it. We know it improves efficiency, it improves access. We have the implementation experience from different partners in different forms. For example, with EngenderHealth, we do family planning integration with nutrition programs, for example, family planning with MCH, family planning with HIV and TB. So there is a lot of implementation experience when it comes to service integration. And family planning program as a standalone program might not be able to cut it when there is a crisis, yeah? But then if it's integrated elsewhere, we know that some services will have to go on. For example, emergency maternal health services will have to go on whether there is a crisis or not. So if we're able to integrate family planning in terms of postpartum family planning or post-abortion family planning, we know these services will keep going on whether there is a crisis or not. Secondly, the technology is growing. Education level of people, is also growing up. And then, there are quite a few opportunities that we can explore. So also let's explore and expand the self-care. Let's tap on this growing population of young people. Let's tap on the technology to advance access to information and services for family planning. And we know this will last, when it's calm or when there's a crisis. Thanks, and over to you, Nabeeha.
Thank you so much for those insights. We now open up to questions from our audience, and we've had many questions come forward. What we've done is looked at common themes and really consolidated around 3 core questions, and I'll direct them to the appropriate individuals. But for this first one, we'll open it up to all 3, Dr. Bashir, Cornelia, and Dr. Anna. And the first question is, how does family planning contribute to the broader goals of sexual and reproductive health and rights? And what specific aspects of these rights are most impacted by effective family planning programs? So anyone who wants to take that first.
Okay, so I'll start. Yeah, so I think family planning achieves a lot of rights, as an individual. So for example, for me personally, I say, family planning helps me be a woman that I want to be. I can choose when I want to have a baby and whether I want to have a baby, and the thing that I want to do as a person. So when we are denying a person that, we are denying them enjoying a lot of other rights. So let's think of an adolescent who is not able to access family planning method of their choice, and they get pregnant when they're probably in their secondary school. They're not able to achieve their education goals. They're not able to achieve their reproductive goal. They're not able to achieve their dreams and the full potential that they might have. But we also know the role of family planning in improving the maternal health outcomes. We know with family planning, we are able to reduce maternal mortalities by over 39%. So why not take that opportunity, especially in countries where we have high rates of maternal mortalities and we give people the rights to live? Thanks, and I'll take it back to you, Nabeeha.
I will take the question, Dr. Bashir here. I think the issue, the title is family planning, it's not contraceptives. So I think the interchange, the use of the interchange between family planning and contraceptives should be very clear. When you say you are planning a family, you are planning a family. You are in a marital or in a union. But the use of contraception, especially for children who are in young people who are in school and whatever, yes, it's a life-saving. Not only is it life-saving in terms of maternal mortality, but it also allows the youngsters to realize their potentials. You are in the university, you have a baby, you drop out, you're in high school, you drop out, and then you become a social, you're ostracized from the community. And therefore, we need to have a thin line. There's a thin line, but we need to really have clarity in terms of family planning and use of contraception. And in some communities, the use of contraception by youngsters is not acceptable. Like in our country, we're having really difficulty. There are age limits, and we need to take this agenda forward, respecting the culture, the legislative concept of context of the country, and so that we don't lose. Because if you say everybody has the right to do sex whenever they want, and including the children, and you dish out contraceptives, as some of our CSOs did in some schools, it really backlashes on us, and we lose a lot. So the appropriate level of education for those who require empowerment in terms of understanding how to use these contraceptives and when to use and when not to use. And the issue of parental involvement is very critical for contraceptives in youngsters. We have a lot of teenage pregnancy, but as a country, we have not come to the level where we say you can do what you want so long as you can use these contraceptives. We are not at that level. And therefore, we need to tread carefully in terms of it's my body, my choice, sort of a mindset. We are likely to have a backlash. The society is still conservative. There is still a lot of religious influence. There's still a lot of cultural influence. The family planning, once somebody's in union, is not in question. But somebody's outside union, it's a choice. Yes, we should have obeyed, but we should not push an agenda against a country's culture and a country's legislation that is already in place. We may lose more than we are gaining. Thank you.
Thank you, Dr. Bashir. So our work within context is very critical. Cornelia, did you want to weigh in on this first question?
I simply wanted to add and say that family planning, as we have said, is not just about the contraceptive. And it is important for us to be able to sit and say, what would it mean to us as the communities? And for us, it is about saying that we're able to improve the quality of life. And that in itself is the right. So it is as simple as that, and I think that is how we need to be able to explain that, and then know that at the end of the day, the different programs that we are doing are geared around improving our quality of life. And quality of life is about our nutrition, how we feed. It is about our education. It is about our access to healthcare, and those are some of the things that we can be able to use to help us when we talk about it. Thank you.
Thank you so much, Cornelia. I also, before we go into our second question from the audience, which is directed specifically to you, Dr. Bashir, I do want to acknowledge that Dr. Rilwan was able to join us. He was also a guest invited for today's conversation. And I just wanted to acknowledge also Dr. Mohammed's leadership and his work in Nigeria. We will be sharing some summaries of his remarks. And Dr. Mohammed is the executive chairman of Bauchi State Primary Healthcare and Development Agency in Nigeria. So we look forward to, in our follow-up recap, sharing some of his points of view and his remarks. as well as having the opportunity to share some of the perspectives that Dr. Sese was going to share today and wasn't able to due to technical difficulties. So thank you for both of these leaders for their ongoing commitment to our shared movement. So the second question from the audience goes to Dr. Bashir. And the question is around technology and what you see as the role that technology can play in improving access to family planning services and information in Kenya. What strategies do you use or what strategies do you think could be used to better engage youth as well as women and other communities who are seeking family planning services? And also, of course, encourage their participation in broader sexual and reproductive health conversations. Over to you, Dr. Bashir.
Thank you. In Kenya, I think the technological space is taking off very fast. And even our revolution that we are experiencing, the Gen Z revolution we're experiencing, is based on social media. You can have 500,000 people on X space discussing issues. Although right now the discussion is about politics and difficulties in life and taxation and the rest, that is a very big potential area where, and the population that are linking in are the population of reproductive age and most probably even less than 25, 27 years, the Gen Zs. So I see this as a real, and Kenya is really networked. Our network reach is almost 95% in terms of the youth. The ownership of the mobile phone telephony is really huge. I think we have about maybe 25, 30 million people owning those kind of gadgets. And putting the information on those platforms is something that can really help us educate and create awareness very fast compared to what we used to do to call communities into barazas and the rest. Community dialogues. Right now, you can have it on X space. And so as a country, we are also digitizing all our services. And therefore, the health service, there's an entity, a government entity that has been just formed called Digital Health Authority, where it's just focused on the health service delivery and it's all digitized from end to end. These are opportunities that you can use both within the government and outside. Of course, we also have a Ministry of ICT, Information and Technology, Communication Technology, and therefore, having a very large population that's educated and that is of that age group and that has access to technology, I think is a wonderful opportunity for us to utilize, for us to ensure that everybody is on the same page. And then our role as government, therefore, is to provide the services they want. Information will be easy to share, but the services and the financing of those services and the products that they require will be necessary. And therefore, they can also use these platforms to really pressurize the government. There was a budget cut on family planning and vaccination. In 2 days, vaccine money that was cut was returned by the National Treasury just because of the pressure on the social media. And therefore, the social media in Kenya is something very strong, and we can utilize those platforms to give the right information to those people to discuss so they can pressurize those who need to make the right decisions. Thank you.
Thank you, Dr. Bashir. The last question from the audience for both Cornelia and Dr. Anna is, very quickly, how do you think we should be addressing the social and cultural barriers that prevent individual women and girls from accessing family planning information and services?
I think the social barriers, as I said, demand, we need to invest more into demand generation, into providing more information about the different methods, more information about the side effects, more information about what it means for the families themselves, more information in respect to their maternal health, more information. The more we give the communities this information, we will be able to address these myths and misconceptions. These arise because we do not have enough information. Can we capacitate our health workers, our community health workers, to be able to answer and dispel some of these myths? When I have a side effect, where will I run to? Let's empower these health workers to be able to come and say that this is what is likely to happen. This is you're likely to have the headache or overflowing. And this is, it doesn't mean that there's a challenge. Empowering them, giving them more information. That for me, I think that is where it starts from. Thank you.
Yeah, and building on Cornelia on information, I think also how are we delivering that information matters. So for example, when you use the satisfied users and expert clients, it helps to hear from the clients themselves. For example, we hear all these things around vasectomy and all. Getting a man who has done a vasectomy and talk about how his libido is still up, will address some of these myths. But also, having like support groups. We have like support groups for males, support groups for adolescent, and they get to discuss about contraception and potential side effects and how people address it, but also addressing from the provider perspective. First doing the overall better counseling than it is right now, where people can predict the side effects and what to do about it, but also helping them have those gender competencies. How are they discussing family planning with a boy, with a man, with a woman? How are they addressing other gender barriers that this woman might be facing in their use of family planning? Would also be very important to be tapped on. Thanks.
Thank you so much. So we're going to wrap up with a lightning round, 30-second response from each of you. And we'll start at the top with Dr. Bashir. And the question for all of you is, leaving us with a message of hope. What do you think is it going to take to deliver on the full promise of the ICPD agenda, recognizing we've made great progress, but we still have unfinished business? What does it take to get us to that finish line? So Dr. Bashir, to you, Cornelia, and then Dr. Anna.
Thank you. I think it takes our patients, all the collaborators who went into this commitment, the partners and the governments. Be patient with the governments and support them, keep supporting them. The dynamics of the population dynamics is changing. There are more opportunities to make sure that this is achieved with the use of technology and information. And therefore, we should not tire. We should not say this is not going anywhere. Even if there is a time limit to this thing, even if we pass that time limit, we should not drop the ball. Thank you.
For me, my 30 seconds, it starts with us. It starts with me as an individual, whether I am in government, whether I'm in the community, it starts with me. And I think that it is important that we work together, continue to build our capacities together, and we'll be able to, the more we hold our hands together and move forward, we will reach our finishing line together, one step at a time, together.
Yeah, and for me, I think I want just to say, the value of family planning in health in any other sector is very well recognized in order to achieve the demographic dividend, but also to reduce the dependence on foreign aid. Therefore, we need to keep pushing. We need to keep pushing to position family planning beyond health. We need to push to keep pushing for domestic resources in order to improve accountability and ownership. But also we need to push for engagement of the people we are designing programs for, be it the young people, be it the people with disability. We have the evidence, we have the tools, we have the resources, but most importantly, we have the people. So together, if we work together, we are able to achieve that promise. Thanks.
Thank you. Well, we've ended on an incredible set of perspectives, and on a very powerful note. I want to thank each and every one of you for bringing your experience, your bold voice, and your dedication to today's conversation, and of course, to our shared journey over the decades. We have so much to feel optimistic about and to celebrate, and at the same time, we know that we can't rest on our laurels, as there are risks and threats to our progress. But your messages today and your conviction give so many of us hope. And it's clear that we have to remain one united, cohesive, and aligned movement so we can keep moving forward until our unfinished agenda for sexual and reproductive health and rights for all people is achieved and it's sustained. I also want to give a very special thank you to USAID and to UNFPA for co-hosting today's event, and also for standing with and for communities each and every day. To all of you who've joined us, not last, I want to also thank you. And know that as you step forward courageously, you're not only stepping forward in full power for our movement, but you're also not stepping forward alone. We deliver on our ICPD program of action. We will ensure that family planning is universally recognized as key to progress, and we'll fight for the agency, autonomy, and rights for all people. And we will do this because we stand together. And when we stand together, we're stronger together, and we can't be denied. Here's to getting the job done. Thank you very much all for attending and for a rich, wonderful conversation today. Let's keep going.